to have some sessions on, and today we are privileged to have three wonderful presenters, and we are just going to be looking at the issues of supporting patients, how to provide emotional, social, and spiritual support for seriously ill patients, especially in the humanitarian setting. So to start us off, we are going to have Anne, who is the head of social work in Washington, in a hospital in Washington, DC. So she's going to give us a lecture. Or are we starting with the case, Erin?
No, we'll do Anne first. Is that okay, Anne?
Yes. So
yeah,
Anne, please
welcome.
Yes, we'll do the lecture. If you have any questions, feel free to type in the chat as we go along. Welcome, Anne.
Thank you. Thank you. Good evening, everyone. Or here, or good morning. I guess in Washington, D.C., it's good morning. I'm going to go ahead and share my screen and go through some slides. Can you see that okay? I'll go to the slideshow.
Yes.
Does that look good?
Yes, yes.
Okay.
That's perfect. Okay.
Today, we're going to be talking about providing emotional, social, and spiritual support to seriously ill patients in a humanitarian setting. So I wanted to start by talking about person and environment, or trauma-informed care. A central theme to social work is person and environment perspective. So how can we getting to know your patient as a person and really understanding how their environment impacts their care and their physically, emotionally, and spiritually. And trauma-informed care sort of goes along with a person and environment perspective, but also taking to an account that more often than not, patients have experienced some form of trauma throughout their life. And really coming from the perspective of how that trauma, whether it's the past trauma or current trauma that they're going through, is impacting their life, not only physically, but emotionally and spiritually. And we'll walk through kind of how to do that. So really, this is just, understanding a patient's life experiences in order to deliver effective care. So dignity therapy, I like to think of this as, who is the person in this case? Sometimes we're framing things around, a patient or a case, and really trying to figure out, who the person is, what is important to them, what are their values. Dignity therapy was developed by Harvey Chechnoff, who is Canadian. And one of the questions that he often asks, he talks about the patient dignity question. And it's a simple, open-ended question of, what do I need to know about you as a person to give you the best care possible? So I often use that in practice. And then some other questions of reflecting on what brings you joy, or even asking the question of, tell me a little bit about yourself as a person. I have found that if you ask, tell me about what's been going on, people often jump right into the medical, or families may jump right into medical. But if you ask, tell me about yourself as a person, or tell me about your mom as a person, what does she enjoy doing? That really then helps reflect on values that are important outside of the context of their illness. So some further exploring really person and environment. When we talk in social work about a psychosocial assessment, here's some key questions you can ask. What helps you cope? Or what has even helped you cope before when you may have been going through crisis? What are you hoping for? Sometimes when we're delivering serious news, we think that somebody might be hoping for a cure, but maybe even there's hope for just spending some more time with family. Exploring how are your spirits, how are your mood, can really bring up whether or not somebody is feeling depressed or demoralized. And again, what brings you joy? Just a quick note on depression versus demoralization. It's important to screen for depression around hopelessness or helplessness, but I think what often can be more common is demoralization, where somebody might be experiencing, for example, a lot of physical pain, and they may feel hopeless or helpless with the physical pain. But if that pain then is treated, they don't feel hopeless or helpless anymore, which is a little bit different than depression. If there's somebody is truly depressed, there's really a feeling of, deep hopelessness and helplessness that's impacting their life and functioning. Oftentimes in palliative care, I think we see more demoralization than depression, but it's important to note with depression, a past history of mental illness can, you want to be more mindful to screen for depression if somebody has a past history of mental illness. So psychological and emotional support. A couple of key things here. Manage physical symptoms, because you often can't get to emotional processing when someone is in so much physical pain. It's important to validate emotions instead of, I know how you feel. Try, it's common to feel sad or worried or whatever that emotion that is coming up, or scared. Instead, or you can say, I can't imagine how difficult this must be for you. It's also important to be aware of nonverbal. So being able to approach and sit with somebody in showing a non-judgmental presence, notice your body language. If you're sort of tense or crossing your arms, or sitting with uncrossed arms, making good eye contact, if that is helpful. And sometimes even just allowing for a lot of silence after giving news is important. And then you can explore, what has helped you what has helped you cope in the past. It could be that this brings up some spiritual screening where faith is very important to a patient. And access to counseling, if you have access to mental health providers in your setting, or counseling that once the physical symptoms are managed can help. So spiritual distress, there was a study done, and this question, do you feel at peace, can often help explore spiritual well-being. And spiritual well-being can be understood as a feeling of peace. Spiritual distress can occur when people are unable to find sources of meaning, hope, love, or comfort, strength, or connection in their life. And this distress can affect them both physically and mentally. So sometimes, people may ask, why me? Why is this happening to me? And terminal illness can often cause spiritual distress in patients as well as their family and friends, and really can, it can impact sources of meaning and hope. And so if possible, if you're talking with a patient who is asking questions and is experiencing a lot of spiritual distress, you can bring in maybe somebody from their own religious or spiritual community that can help with that. So spiritual and emotional support, it's important to listen to a person's story and show compassion. Try to avoid giving answers or advice, including imposing our own beliefs. Sometimes if you're not sure what to say, just allowing space for some silence can help, or asking questions around, tell me more. If somebody's saying, I'm not sure I can do this anymore, I'm in so much pain all the time, you can say, well, tell me more about, statements of, you're not sure you can do this anymore. Tell me more what you're most worried about. If somebody is talking about, I just really want to feel better, you can ask, instead of a lot of intellectual questions, more questions focused around their body. How do you know in your body when you feel better? What does better look like to you? Because better might just be being out of the hospital for a period of time. It may not necessarily mean having their illness be cured. Sometimes a good question to start with is asking, how is your body feeling today? That can explore whether or not it's, I'm having a lot of pain, or I just feel weak, or today is a good day physically. Avoid false reassurance if the person talks about death or dying. Sometimes a patient, if you're present may say, I'm just worried that I won't be here long, or I'm worried that I'm dying. And it can be really hard to sit with those strong emotions. And our instincts might want to be to reassure the person that things are going to be okay. But really sitting with that and exploring, if we are talking about the end of this life, what are you most worried about? And that can allow that space, because when we're talking about death, it can be very scary to have those conversations, and they may not feel comfortable talking or not really have the words to talk with their family about what they're most worried about. And some people feel reassured to know that their questions and struggles are experienced by many facing life-limiting illnesses. So even reassuring them, if somebody is talking about being worried about dying, and I'm worried about my family, I'm worried about what may happen to my kids, you can state, well, that's very common to feel that way. Of course you would be worried about what will happen to your family when you're no longer here. There was an article that's in the references by Ratner and Berzoff called Sitting with Suffering, and that a lot of what we do is, and what is so important in this work, is not even the words that we use, but showing up and being able to sit with suffering. And they go on to discuss how suffering is intrinsic, is really common at end of life. And so they talk a lot about common things that patients experience at end of life, death anxiety, loss, and not only loss of relationships over time when somebody is ill, and feeling like a burden, just worry, even though family is willing to take care of somebody, just feeling like they're a burden as their illness progresses and they become more dependent on family. Very common, we talked a little bit about worry for family. Not only worry for family currently of feeling like a burden, but sometimes financial worries for family. If somebody is the person who was, making money and providing for the family, worry what's going to happen when they're no longer here. And then loneliness is very common. Not only just the loneliness of maybe being away from family and being in the hospital, but just feeling very alone in their illness. If they're not around maybe other people that have the same type of disease that they have, there can be a really strong feeling of loneliness and isolation. And so just to summarize here, I put out some common phrases that I have often heard, and instead of, and then on the right-hand side, there's suggestions that you can try. So I know how you feel. So instead of saying, I know how you feel, you can try, I can't imagine how hard this must be. Instead of sort of that natural instinct we may have to reassure people of, don't be sad, you can say, it's okay to cry. Of course you would be sad. I can't imagine what it's like to hear this news. And really showing that supportive presence. And instead of don't worry, you can say, it can be really scary to think about dying, and really exploring what are you worried about. And instead of, you will find meaning, you can ask questions around what brings you meaning or what brings you joy. So I'm just going to stop there to see if maybe there's even some other questions that anybody's been asked by a patient before around spiritual or emotional distress that they weren't sure how to respond to. And you'll have these slides, so you'll have these prompts to use. And then also just take a minute for kind of any questions before we move on to the case. You can either just unmute yourself or you can put them in the chat.
Feel free to type into the chat or just to unmute yourself and ask a question.
I just have a question, Anne. So as we are engaging in more like reflective practice, we've learned in palliative care that's really important. Where do you draw the line between, like, for example, if you feel like you didn't have a very good conversation with the patient and the family, do you apologize? Do you kind of say, can we try that over again? Even just with your basic examples of the left and the right column, if you've known you've done some stuff on the left and they're like a pretty close family or a patient of yours that you see regularly, do we become vulnerable and say that, or do we just kind of start the next conversation in a way now that we know a bit better? How do you suggest we do that?
I think it's always important to trust your instincts. And so if your instincts are like, ooh, that didn't go well last time, and let's say you're seeing somebody again in a week or two, I think you can acknowledge that and say, you know, I'm not sure that things went well the last time you were here. And I want you to know that I'm here to listen. And how could I be most helpful today? And that might be a way to just acknowledge sort of, I was thinking things maybe didn't go well the last time, and I'm wondering how I could be most helpful today. And then spend really a lot of time that next visit listening. But it can be hard to do that. It can be hard to be vulnerable and to acknowledge that, oh, and sometimes you can even use a line around, if you notice that they're having a reaction to something you say, even in the moment, you can take a minute to say, oh, I think maybe that I didn't do my best to communicate that well. I can see that there's some emotion coming up there. Are there any other thoughts or questions? And some of them may come up too as we go through the case.
Yeah, if people, Dr. Esther, did you want to add anything to that? If there's no specific questions, our case is quite extensive, and I think it's a really good example. It's from one of our contacts in Kenya. So we could spend a bit more time on that and then relate it back to the talk for today.
So far, I can only see comments that it was a nice presentation. So I think as we go along with the discussion, if there are any comments or questions, we can respond to them at the end of the first presentation. So I'm going to welcome Annalice. Annalice is a palliative care nurse working with IRC in Dadaab for over 10 years. She's very passionate about palliative care, and she's heading the unit. That's a focal point of palliative care around that region of Dadaab. So Annalice is going to give us a case presentation, then we are going to use that for discussion. Welcome, Annalice.
So I'm going to share my screen. Annalice and I were working on this case presentation together. In the past, with our ECHO programming, you guys have seen more of the faculty presenting cases and examples of the work that's being done to help with teaching. But we're going to actually begin to switch where we have participants and you guys who are working in the field share cases and presentations with us, so we can begin to talk and work through cases that are recent and relevant to our work. So Annalice and I were working with this patient for the last several months, and she did a great job putting together her presentation. So I'm just going to share the questions that I would like you guys to think of as we go through this case, and then Annalice will explain what they did to take care of this patient. So the questions I want you guys to remember as we present this case for the next 20 minutes or so is how do we manage a patient with multiple comorbidities that's experiencing heavy symptom burden and suffering? How can the community support the patient and the family during these times? What roles do spiritual leaders play? And the number 4 is, at what stage is it appropriate for patients to be enrolled in palliative care services? And the final one is, which role did palliative care play for the patient in this situation, especially related to end of life? So how did they support the patient during that time? So Annalice, if you want to unmute, and we can begin the case now.
Okay, good afternoon, everybody. Can everybody hear me? Good afternoon.
Yeah, yes, we can hear you. You sound perfect.
Yes,
Okay.
we hear you.
Yeah. Yes, we can hear you. Nice.
Thank you. So this is a case of a patient, 50 years old, a female. She was first diagnosed with the pregnancy-induced diabetes mellitus and then hypertension at the same time in the year 2002. And then later on at 2022, she was diagnosed with, 2012, she was diagnosed with breast cancer. And then again at 2020, she was diagnosed with retinoblastoma. And then the patient, we first came in contact in 2019 after having enrolled in a non-communicable disease clinic in 2018. But because she was, the follow-up was not all that well, she defaulted, and then we managed to trace her, but we did not find her in the camp. Later on, she came back in 2019 now, when she came with the results of having diagnosed of cancer of the breast stage 4. She was just referred from the oncologist clinic back to the camp, told to go and be reviewed attended to by palliative care. But then we did not have the palliative care team. And then it's when 2019, around December, November there, we trained for palliative care. And then we took over the case. We started working with the patient. But it was so difficult for us to do anything with the limited resources. But we managed to do what we could. We picked up the case with the community health care workers. We could follow up to the home. Several she was admitted in the ward. Then, as we can see, upon taking over the case by palliative care team, we had a meeting with the family members, which occurred before, when she was in the ward, before she was discharged. That was the spouse, the daughter, the brother, and the clinician working at the non-communicable disease clinic, then the community health worker of her block, and then we also had the sheikh on top in the team, the nurse, and then the mental health nurse was also present, and the palliative care clinical officer was also present. But just because we had that formal training with the KEPCA, that which had empowered us with the knowledge on palliative care. And then the family raised money with the community initiative that was to support the patient, because we could not refer her, and then they decided to raise money. So they took the patient to a place where we don't know, but she was done mastectomy there. And then when she came back again in 2020, is when we noticed that she still had the wound, despite the myomectomy. The wound was still there at the scar, and she had swollen lymph nodes on both axillary, and then she was anemic. She had a HB of 5 by then, 5 grams per deciliter, and then Okay. And then that's the time when she had to be admitted, transfusion was done. And throughout this time, we were making sure that the diabetic mellitus sugars were well controlled, and the hypertension, she was taking her drugs. The pain was too much for her, and we didn't have any painkiller, strong painkiller opiates. We didn't have. We were only treating her with the paracetamol, and the tramadol is the strongest that we could get. That was injectable tramadol. But the vomiting was also too much, and we could just treat with the promethazine, Lacil, and we continued giving her nutrition support. Before she could take frequently and freely, but later on, she started also not feeding well, and then on parenteral intravenous fluids, and all those, and then antibiotics were given. Wound dressing, wound care was done very well. The wound was improving. Then again, she was discharged home. On discharge, we managed to talk to the family because she could not be moving from her home to the hospital on daily basis. It was a bit tiresome for her as she was growing weak each and every time. So we instructed the family how to do dressing in the home. We provided sterile materials, and then she could come alternately, or on after 2 or 3 days she could come for the same. Then we managed to invite the ophthalmologist to, there was a visiting ophthalmologist who managed to review her eye, and then he had the diagnosis. And because there's not much they could do, they said it is the effect of diabetes mellitus plus the metastasis of the cancer. So the patient did not get any much help from the ophthalmologist, but we just managed to dress, daily dressing, cleaning with normal saline, and then we just kept on. Kindly mute Al-Shugri.
Are you okay, Annalice?
Yes. So next slide, please.
Go ahead.
Yeah. So the patient,
see?
we managed to support the patient nutritionally by the nutrition team, who provided all that she needed. By then, she could only take milk and some porridge. The milk was there, and the flour was also there. Next slide, please. So the patient had total pain. That is, she was both physically, psychologically, spiritually, and socially, emotionally, financially. She was sick, totally sick, because this is a patient who had drained everything that she had for the past year, going for those examinations, investigations, and tests from a different place from here. And then, having been a mother of 9 children, and the 8 passed away, she only had 1. She was tormented already. She was in depression even before the disease overpowered her. And then Now, given that she has only one child who dropped out of school because of taking care of her, she was also sick socially. And then the effect of the medicine that she was getting, the diabetic medicine, the hypertension medicine, and now it comes to the wound, which was oozing, false smelling. She was also fearing. She saw herself as already she's stigmatized, but in real sense, she was accepted by her family because they took care of her. They could not leave her, but in herself, she could not see that. Then she also had the denial for referral to specialized. She was denied because when somebody is diagnosed of chronic illness, it's not easy to access any special medicine from the humanitarian settings because of the expenses, I think so. And then also the numerous hospital admissions. She could be admitted, the sugars are too high, we can't control on oral medication, she has to be admitted. And then the blood anemia, she had to be admitted, transfusions, all sorts of things. They were really stressing upon her and the family, because the family had to come and stay with her in the hospital, and the home was now to be left alone. So everybody, the family, the patient, they are all stressed in one way or another. They went through the pain, but thank God that she kept on calling on the word of God. So the pain of daily dressing the wound and the nursing care, actually what the nurses did, they did a good job in the ward, despite even when the palliative care nurse was absent, the care continued and the patient was made comfortable. Daily dressing of the wound, monitoring of blood pressure and blood sugars. There was personal hygiene. They made sure that the patient is kept clean and dry and in hygienic condition, bathing, and even sometimes it reached a point we had to do bed bathing and then feeding and diet management. The nutrition team really supported us. They had to talk to her and even the relative. They had to teach us which diet she should use, and also we ensured she was well hydrated by giving intravenous fluids, and then making sure that her oxygen levels were to normal, and then medication, antibiotics were prescribed on time, and they were all that she needed. Then they made sure everything done to her was documented and things kept confidential, so that other patients, maybe they could ask, what is she suffering from? Because privacy must be maintained. We kept her in the isolation room, which made it easy for us to attend to her. Next. So the psychosocial and family concerns of the mother, the patient rather, having married with only one daughter, and she's in adolescent stage, she had fear that maybe her daughter may elope or something may happen to her after her leaving the daughter behind. She was worried when death comes, the husband the spouse rather, may get another wife. What will happen to her child? But she also had a boutique before the illness overtook her, and then now everything that she had was used on her treatment and travel and all that. So she was worried when she's leaving her child and family behind. What will they use? So sometimes she could even refuse to go for medication because now she saw there is nothing remaining behind for them. Then the extended family lived with her also. The brother and the wife and the children were with her in a very small compound. If I were to show the picture, but it was a small compound, but they managed to live there. So this also brought stress on her because there was no privacy. with her wound and everything. She at times could wish she could remove her clothes and stay naked, but she couldn't because of the environment. And then the relative also, she died, and then her family remained in, okay, they accepted because they had already grieved it before. 20 years they were grieving with her. So there was no much to be done, but the girl really grieved a lot. She could cry every time we visited them as a group, she could cry. But she had, before she died, she had hope that when she is done the surgery, when the surgery could have been done successfully the way it was done, she hoped that she would live longer, even to see her daughter marry, and she could see the happiness of having grandchildren. Unfortunately, it did not happen. So the family got very upset that there was no support to them at all in referring the patient to the proper oncologist care. Those were all the concerns of the family. It's an ailing family, actually. Next. And then on her spiritual concerns, the patient and the family had faith and hope in the healing of the higher powers. They wished that when they minister, they will be better off, but it did not happen. Then, but the sheikh was so supportive. He supported them through prayers. He encouraged the family. And then when asked if she had fear about death, she said her life belongs to God, and there is nothing she has control over. When God says it is time, she will let it go. And the family also accepted. They say when God says it's time, they will not prevent her. They will let her go. And then the family also will encourage her and everything. The bereavement part was strictly not handled with the female. The females are not allowed to go into the bereavement part when the person dies. So this daughter was left behind when the mother was being buried. She did not witness. She cried a lot at home, but later on she's speaking on now with lots of counseling and encouragement. She's speaking on. Next. The family understood very well about diabetic and hypertension, and they don't see it as a curse, but cancer is seen as a curse, but most of them is associated with demonic aspects. So that's why they take a long time in prayer than going to seek medical help. And then also people, when they have the diagnosis of an illness that is not common, they will call for prayers, and then they delay to go to the hospital. Once a patient is also confirmed with cancer and often told it is advanced stage, they return only once they have increased symptoms. They will just go home and start praying, because they know even if they came to the hospital, they will not be referred for any intervention. So most of the patients with cancer, they are either just at home, or they decide to raise funds for themselves, and then maybe they go to somewhere for proper medication. Most of them go to the country of origin, and then they will come back later. And then the management of the patient was also complex. That the patient, we did not understand whether after the diagnosis of the cancer stage 4, what happened, whether they were informed of or whether they were not told. Because when we asked, they just said they know it is cancer stage 4. They didn't know anything that could be done. So we tried to explain to them that once it is cancer stage 4 and looking on the results of the blood test and the CT scan and the MRI that was done, we just found that this one is stage 4 that had spread, and then given that she also has diabetic and hypertension, that was now at that time it was in crisis. The blood sugars were above 30. The blood pressure was 160 over 100. So this was a case that we couldn't know what to do, because she at times came when she's almost falling, she's crying, like that. Then in the management, there was a strong collaboration between and partnership with the departments. We also partner with the Lutheran World Federation, which deals with people with disability. This was a person with disability because having had the eye, she was actually half blind because one eye was almost knocked off. It completely died, and then it had a wound. So we had to involve them to give her walking aid. So they managed to provide a walking aid. But in the proper management, we involved the community health workers under the community health program. We also managed to involve the nutritionists, really supported us very well. And the mental health were involved in the counseling because we did not have a proper psychologist. So mental health officer, they really supported us in counseling the patient. And then the clinical staff at the non-communicable disease, they managed well the diabetic and hypertension. That's how we managed to calm the situation down. And then the medical officer were there always ready. When we call that the patient has changed of condition, we could not miss any support from the medical officer. And the nursing officers were there always for her. Everybody was really ready to support this patient. We managed to support the emergency department. Whenever she came, they could attend to her immediately and refer to the appropriate department. If it is admission, they could admit her from that point and then take the lab sample to technicians and technologists. Time when there is a transfusion, they have to bring donors. But for this one case, they took her special, so they could not ask us for donors. And then also the spiritual leaders could not abandon her. Always, every day, they were there to pray with her and patient. Every drug supported me. That's how we managed. So, to sum it up, this patient is a 50-year-old lady married with one living child. Out of 9 deliveries, only 1 is living. She was diagnosed 19 years ago. That was before 19 years ago with diabetes mellitus and hypertension. And then 10 years later, advanced cancer. 2 years later, partial blindness. Then the mastectomy was done in 2020, and after that she suffered real continued. There was continuous care and due to the diabetes, then actually we used to cover it, but thank God it never came out until her last day. And then there was different the clinician to make decisions. Actually, each time you not, you still want to give antibiotic, but it was so difficult for us which time to give and which.
We might have lost Annalice, but that's okay. We are nearly done the case. So I'll just finish just by saying that the patient unfortunately died in May just recently, and the team is ongoing with their bereavement support with her spouse and daughter, especially the daughter, as Annalice had mentioned, who's feeling a serious loss of hope going forward without her mother. So we'll go to the final part of the case and bring it forward for discussion. I know that we have quite a few of our faculty members on the call today, as well as now most of you have had an introduction to palliative care. So I'd be really interested to hear what your thoughts are on this patient. So number one, how do we manage a patient with multiple comorbidities, such as this one that we've just shared, who experienced such a heavy symptom burden and suffering? So not only from the wound, but the pain of loss that she's experienced, as you've heard her story. What could the community do to support this patient and family? We did hear from the case study that they raised a lot of money so she could return to her country of origin to get her surgery. But what are other ways the community could have supported the patient and the family? What roles do you think the spiritual leader played in her situation and providing support to them, as we talked today during our lecture about spiritual care of patients with complex needs? And then in this situation, what stage was it appropriate for the patient to be enrolled in palliative care? We heard from the story that the patient was referred to palliative care when she was diagnosed with advanced cancer. But it was only recently, I think, after her surgery that the palliative care team got more involved. And then how can the palliative care team, could they have helped her during her end of life, in which I'm sure her pain and suffering were increased. So we'll put it out to the group. I'll share the questions on the chat. I'm going to stop sharing my screen now, and I'll put the questions in the chat, and maybe we can have a discussion as a group about this case. So if any of the faculty that are on the call have a comment.
I was just wondering, Erin, how maybe things could have been different if palliative care had seen her prior to the surgery.
Right.
Even in some ways to prepare the family for maybe what to expect and support them.
Yeah, I think Annalice at IRC does many roles, and I think there's a few other people from IRC on the call today, but you guys could maybe explain your team dynamics a bit. I know Annalice also sees patients that are not palliative, but would be, I think in this situation, would have been really helpful if before they went for surgery, they had some counseling that could have been done. It sounded like they had their team meeting, which it sounded like was a successful meeting, but didn't lead to a change in the decision-making that the family made and the community made to go for surgery. Dr. Esther, I see Dr. Ali is on the call with us. Do you have any comments on this case that could help the IRC team moving forward?
I've listened to the case and I was just thinking this woman had a lot of unresolved grief, having had 10 pregnancies but only one child, and a lot of comorbidities. So I was just wondering what resources were available in terms of supporting her. I'm not sure about the composition of the team there in IRC, or maybe what further could have been done to support her. The community's roles, did they get any further support apart from just what was provided by the healthcare providers?
Yeah, I think Annalice is back on. Annalice, were you guys able to do, I know you said the mental health team was involved. Do you know if she was able to go through any sort of trauma support because of all the pregnancies that she had lost in the past? Is that something that's available, or are there limited resources where you are?
Okay, unfortunately, we do not have, by that time, we did not have a psychologist, but we managed to do with the mental health team. We invited them, they tried to counsel her, they talked to her, and then we also used the gender-based violence psychosocial support, managed to support that way. But unfortunately, our team, palliative care team, is weak. We only have very few members.
Yeah.
We don't have an oncologist. We have a medical officer, general medical officer.
Yeah.
We have a clinical officer. Yes.
So probably the support that she got from a mental health perspective, especially related to the previous losses, like that she's experienced in the past, even before all the comorbidities that she had, was definitely lacking. So she probably had very, like Dr. Nafula was saying, unresolved grief as she went into a very difficult situation with a chronic advanced cancer.
There's a comment here in the chat from Maculin that how can we manage expectations, especially on the role of interventions and prognosis? This patient was hopeful that with surgery she will stay for longer. The relatives also seemed to be disappointed when she died. So how can we handle some of these issues around prognosis and the expectations of patients?
Yeah, I think it's a really good question, Maculin, and I think it goes out to the group as we continue to support one another to raise awareness within our colleagues, especially within organizations like IRC or even Annalice was sharing some of the other partners that they work with. I think it definitely requires a team effort to be able to begin to change people's perspective on prognosis. And I think it just requires everyone to be on the same page. So not only the inpatient team, but the outpatient team, the emergency team, everyone kind of saying the same thing to our patients and families, which is really difficult when the information that we are sharing is not good news. But yeah, maybe Dr. Ali, do you have any comments on that, on how we help people with difficult prognoses?
I was just thinking this hello, can you hear me?
Yeah, Rose, can you go just right after Dr. Zippy?
Okay.
Thanks, Rose.
Yeah, thank you. I was saying that it probably is a situation where there are multiple problems for this lady. Just made me thinking that one of the things that also helps patients go through the psychosocial, emotional issues and even spiritual issues is referring them back to the community that they kind of relate to. Were there any support groups? This lady has been sick for a long time with the NCDs. Were there any support groups during the NCDs? Did she have a clinic she was attending? Was she able to relate to those people? Were they able to support her? And also within the community itself, was there a support group for her malignancy? So I think remembering that support groups also play a very big role, where sometimes we fail as clinicians because maybe we don't have the time, we don't have the ideal team. These groups provide a lot of psychosocial support, and the patient is also usually able to relate to them because they are the people she is with maybe closely than she is with her medical team. And also even the issues of culture are very important because you can see that even her child is, I don't know if I got it right, the child didn't go to the funeral or something like that. So again, how do we bring in those issues of culture when you're doing counseling for the family members? But I think the team that the team that presented actually tried their best under the circumstances. They did their best. Sometimes we might not have everybody on board, but one of the things we need to remember as palliative care providers, we actually multitask. So if the patient needs counseling and if the first contact person, you need to also start counseling that patient, providing mental health, providing psychosocial care, spiritual care, as you look for who is the best person to support this patient. We can't tell a patient we will not be able to do this for you. We should be able to start immediately so that they don't feel, we have left them or we are, kind of giving up on them. So one of the things that I always tell people in palliative care, you have to learn to multitask. I learned to multitask when I was working at the hospice. Sometimes I was a spiritual caregiver. It's not my specialty, but sometimes I dress the wounds. I'm not the best. The nurse is the best for dressing wounds, but you actually learn to multitask because when the patient is with you, you're the person that they're looking up to help them with their problems. But thank you, team, you did a great job. Thank you.
Thanks, Dr. Ali. Rose, do you want to share some comments? Sorry about that. Haribo.
Yeah, it's okay. Thanks. I think the presenter was so good, though I didn't get it on. But according to the case presentation about this lady, I think she needed the holistic approach of approaching her because she had both psychological, losing all her children. She had spiritual care problem also. She had the comorbidities, which is a physiological problem. I think even she had even a hope of getting better. And what I didn't see, though the team did well, but I think in the refugee camp there wasn't a holistic, there wasn't a team, though there were a few. Though we say there is nothing you cannot do, but there is something you can do in palliative care. But I think she died when really she had a lot of unanswered questions in her mind and even her family, because she was hoping of getting better with surgery, which never came out well. She had a kiosk and she was really, I think, having a problem of where to leave her daughter, who was a teenager, whom to leave that daughter with. I think she died, she didn't die, according to my assessment, I think she died with a lot of unanswered questions in her mind. So I think as palliative care practitioners, we should really see a patient, not as a disease, but a patient, and we deal with the patient as a person, not looking at the disease mostly, because I think people came from NCD, as Dr. Zipa said, there were nobody. It's just a team which I think organized itself, which was very good. They did a great job. That's my take.
Thanks for sharing, Rose. Yeah, I think it can be really difficult. And just to add on to what Dr. Ali was saying, sometimes you do need to take on roles that we aren't really trained for, but we see the need. And I think that's probably something that Annalice and her team really, they did. They saw such a huge burden that this patient and her family subsequently experienced serious health-related suffering, and they did try to come together. So I think as we continue to learn and support and understand the needs of our communities, especially in humanitarian settings, it's really important that we all come together and we continue to advocate for better services. I know it is difficult. It's an uphill battle for people like Annalice and her team at IRC to access better resources, but we will continue to support you in the work that you are doing. We will continue to advocate and to share the stories of the patients. I know people like Dr. Ali and, Dr. Zippy and Makulin, the executive director at KEPCA, as well as Dr. Nafula at KNH. We're all in this here to support you guys in what you're doing. We will continue to take the stories and the cases forward to try to allocate more resources to the work that you guys are doing in the field. So in our program here at ECHO, we are here to support your education and continued learning, and definitely also to stand with you in the very difficult cases. So Dr. Nafula, do you want to just explain what we'll do for the next few weeks? Sorry, the next few months till the end of 2022?
Yes, so, okay, before that, there are some comments here.
Oh yeah, sorry.
Yes, Peter says that he's puzzled that when the family heard that a patient has been diagnosed with cancer, they had to take her for prayers. There are some things that God gave human beings to address by themselves, such as knowledge, but yeah, people still always turn to spirituality. I think it's very important when we are assessing patients, especially in Kenya, to remember that bit, or in sub-Saharan Africa, that spirituality plays a very big role in their care and even what choices they make for their treatment. Anne says that she was also thinking prior to the surgery, we could tell her, I hear your hope that this will go well, and would it be okay to talk about what I'm worried about? Sort of opening a window for the patient to give us their anxieties. This was a very good presentation, thank you. So for the next alternate weeks, or every few weeks, we are going to be doing some topics, case presentations, and some of the topics that came up. And we do need people to volunteer to give us a pediatric case and a pain case. If you're willing to give us a case presentation, please get in touch with Erin. So until the end of November, that is early December, we'll have 5 sessions in total. So we are going to be notifying you at least a week in advance so that you block off the time on your calendar. So it will just be the same approach as today. We are not having breakout rooms. We'll have a lecture, a didactic lecture, followed by a case presentation with a discussion. So you feel free to share any cases that you might want to present around the topics. Erin, is it okay for you to share the topics or the dates for the next few sessions so that people can block off their calendar?
Yeah, I just put it in the chat. So our next one is October 25, then November 8, November 22nd, and December 6. I'll share this on WhatsApp. Next week, or sorry, in 2 weeks, we'll be discussing advocacy. So how can you advocate in your workplace, with your supervisors, beyond that, within your organizations, depending where you work, to improve access to palliative care. So that'll be a really interesting discussion. David from KEPCA will be speaking on that, and then we'll be sharing a case discussion about some work that was done in Bangladesh and some things that we can learn from their work. And then we will continue with breaking bad news and communication. In November, we will talk about opioids and titrating opioids. If you have access to opioids, how do you increase doses as patients need it? And then we'll finish the mentoring sessions of pediatrics, palliative care. So we'll keep in touch. Hopefully in 2023, we'll be offering another certificate course, another introduction to palliative care, as well as a pediatric palliative care program, certificate program through the ECHO platform. So please keep connected with our group, stay connected on the WhatsApp, and invite your friends. These mentoring sessions are open to everyone. I'll just add in, for those that are not on our WhatsApp group, I'll just add in the link to the WhatsApp group on the chat. And yes, thanks everyone for being here today. And thank you, Annalice, especially, and Anne for the lecture. Thank you guys.
Thank you everyone for your time today. Thank you for the participation. We are ending the session now. Feel free to leave. Thank you.
Claro. Yo,